and the other competitor, other systems, and they have found on the basis of 94 samples, they have 63 samples which are born negative on the both systems, and they have only one sample which was positive on the SNIDE and the negative on the other systems. That's why the negative rate is 98.44. If we talk about the positive rate, they have a 29 positive samples which were also positive on the SNIDE platform, and on with the other platform only one samples were considered as an negative in the SNIDE and the positive on the other systems. So on the basis of this negative and positive correlation between the SNIDE and the other assay, the positive rate is in 96.67. So the overall agreement is around 97.8, or you can say 98%, which is an ideal for the comparison study if we have done for the with the leading brands. If we talk about the TMA, as we know that the TMA is a thyroid microsomal autoantibodies testing. It's basically thyroid microsomal is an antigen which exists in the thyroid epithelial cells cytoplasm. And when it's entered into the bloodstream, it produces the specific high titer antibodies. So, considering the evidence that that the TPO is a major autoantigenic determination of the TMA, so the TPO thyroid peroxidase has also induced the system to produce anti-TPO and the TMA, which is the thyroid microsomal antibodies. So you can see that the TMA test can also be used for the diagnosis of the autoimmune thyroiditis, which has a positive response in more than 30% cases, or in the positive rate of the 30% cases, and the chronic lymphocytic thyroiditis positive rate is more in 60 to 95%. If we want to diagnose the Graves' disease with the TMA testing, that's in thyroid microsomal and autoantibodies testing, which increase in the Graves' disease from the 50 to 85%. If a subacute thyroiditis with low positive values also helps this TMS assay for the diagnosis of subacute thyroiditis, and in certain chronic disease, that's in chronic hepatitis or SLE's patient, this TMA test is also used for the diagnosis of these conditions. So if we compare the autoimmunity highlights testing with the testing of TMA and anti-TPO. So you know that the TMA and TPO show the best agreement between the thyroid autoantibodies to rule out the autoimmune disease, and the TMA and TPO are the most sensitive marker of the thyroid disease. You can see that the TSH percentile is there, interval of the TSH percentile is different at different values. Once they have a TPO and a TMA markers, to test the prevalence of the thyroid autoantibodies in the lower, means the first and second, third and fourth, and the upper percentile of the thyroid distribution study of this participant. So you can see that in the first stage, there is 31.8 and 31.8 both the TPO and that, and then the percentage of the TSH distribution from 4 to 97, 98, and 99, 100 percentile of the TPO. So, according to this data of 3,097 individuals, which were above age of 40 years, were randomly selected for the population of the specialties of the Cremona Hungary, and there are 2,096 individuals, which are the 66 or 67% agreement of the participation in the survey, and we found that these two assays are very clinical utilization to diagnose. So if we compare the technical information and the specification for this test, like if we talk about the pack size, again, we have an edge of low pack size along with the free calibrators and control, and both have a sandwich principle of TMA, human serum, and the next generation of second generation of Neglumi TMA thyroid microsomal antibodies testing. We have an improved sample type of serum and plasma both, and we have an SNIDE internal reference substances used for the standardization of the TMA cycles. We have a 29 minutes essay with a 2-point calibration in 28 days stability, which is enhanced in second generation as compared to the first generation. And we have a linearity of 1.5 to 500 IU per ml, on the basis of which we have an edge with the other competitors. So if we wants to review the TSH receptors antibodies, so what are the three thyroid receptors and antibodies? As you know that these are the basically responsible for the clinical manifestation of the Graves' disease and specific biomarkers for the autoimmune thyroid disease disorders. So if we talk about the thyroid antibodies, depends on the receptor signaling. So this is a TSAB, TSBAB, TGI, and TB2. So basically, the thyroid TSAB is a thyroid stimulating antibodies, which function is to stimulate the CAMP production and iodide uptake to the thyroglobulins, and then help the production of T3, T4. While the thyroid stimulating hormones, receptor blocking antibodies has a leading impact on the inhibits the TSH induced CAMP production and then iodine intake for the thyroglobulin synthesis. If we talk about the TGI, that's the thyroid growth stimulating antibodies, which major function is to stimulate the thyroid cells growth. So TBII means thyroid binding inhibition immunoglobulins, which inhibit the iodine 125 TSH binding to the receptors. So these are all the thyroid autoimmune disorders which can be further differentiate on the basis of these thyroid antibodies testing further classification. If we talk about the thyroid panels, receptors antibodies, we have a hyperthyroid differentiation diagnosis on the basis of the Graves' disease. You can see that the hyperthyroidism differentiation diagnosis, according to the 2016 American Thyroid Association guidelines for the diagnosis and the management of hyperthyroidism cases and other cause of thyroid toxicosis. They have an etiology of thyrotoxicosis should be determined, and then the overall the clinical presentation of this biological evaluation is required, and the measurement of the thyroid antibodies is also recommended, along with the determination of radioactive iodine uptake, and the measurement of thyroid blood flow on the ultrasonogram is recommended to diagnose with the hyperthyroidism differentiation diagnosis and the other cause of thyroid toxicity. And for the monitoring purpose, thyroid stimulating hormone receptor antibodies and the treatment and the recurrence of the Graves' disease and guideline for the medication according to the 2016 American Thyroid Association guidelines for the diagnosis and management of hyperthyroidism and the cause of thyrotoxicosis. They have a thyroid antibodies as an indicator that ATD therapy may no longer be necessary, or its continuation may put the fetus at risk for the hyperthyroidism. So even the mother is euthyroid out the medication. So this is also as good tools for the Graves' disease recurrence and the treatment monitoring for this purpose. If we talk about the risk for the thyroid disease for the pregnant women and the neonatals, according to the 2000 American Thyroid Association guideline for the diagnosis and management of the hyperthyroidism and other cause of thyroiditis, it's recommended that the high risk thyroid patient assessment is need to be receiving the ATD for the DD disease when becoming a pregnant, found to be have a pregnant women have thyroid antibodies levels, measure as an initial pregnancy visits, and the diagnosis using of sensitive assay we make we lead at again at the age of 18 to 20 weeks of the gestation. So for the high risk of the thyroid disease, this is recommendation. And then if we want to go for a further thyroid panels receptors disease diagnosis, it's a very clear and more accurate treatment. The comprehensive menu is there so to rule out the Graves' disease. Then the goiter physical findings is there, plus antibodies, plus and the eye size diagnostic finding, and the treatment is anti-thyroidites or RAI or surgery is recommended for the Graves' disease. And even with the transit thyrotoxicosis, subacute thyroiditis, toxic multinodular goiters, iodide-induced toxic adenoma, thyroid carcinoma, exogenous hormones, hydatidiform roots, and the choriocarcinoma with the TSH omas. These are the all goiters physical findings with the small thyroid and metastasis, and the modules and the goiters nodular goiters condition in which there are different diagnostic finding with the values of this thyroid receptors antibodies that are recommended. So if you further goes to the thyroid panels, so we can compare the thyroid stimulating hormone receptors antibodies with the Roche. So if you want to take a break, please let me know, because since 1 hour and 45 minutes we are in session. So if you want to take a break, please let me know. You need a break? Okay. Okay. So here we can see that in this thyroid antibodies first generation versus the Roche anti-TSH assay, we have a flexibility of free of cost calibrating control along with the 50 test, and the sample volume is less than even with the Roche anti-TSH. So with the minimal volume, we can run this thyroid antibodies testing, and we have a serum sample type and the sandwich principle base technology we are using. Then diluent is included in the assay. So if in case of high value, higher than 30, you can dilute automatically, and the other assay time is just 31 minutes, which is equally good to the Roche assay. We have a traceability of WHO second internal standard of 08/204, but the Roche standardization is different, which is a 90 by 672 standardization. This is the difference. If we more talk about the second generation comparison of SNIBE versus the Roche, is that we have a 50 test and free of cost calibrators, but we have a indirect the sandwich principle as compared to the competitors. We have a serum and plasma both recommendation, which we have an edge versus the Roche sample type. Here we have a minimum sample volume, and we have a calibration interval of 1 week as compared to the TSH of Roche, which is required everyday calibration. 1 day calibration stability is the big challenge for the end users. If we talk about the calibrators and controls, we have a free of cost, but with the Roche, you need a lyophilized calibrators, and the pretreatment reagents and buffer is required along with the additional controls. If we talk about the diluents, yes, we have included in the reagent. If you want to buy the anti-TSH kit with the diluent, you need to purchase it additionally. We have a reference range of 1.5 less than as compared to, which is better than anti-TSH, and we have a linearity of 1 to 40 as compared to this the Roche, which is 0.8 to 40, and we have a test time is 38 minutes as compared to the 27 minutes. We have a standardization of traceability, which is equally good as compared to the Roche assay. So if you talk about the SNIPE, a comparison between the first generation thyroid antibodies and the second generation thyroid antibodies, the key factors are the sample type. In the second generation, both sample types are recommended, and the other key factor is the improved linearity range. This linearity improved range will give the more confidence to the customers because the traceability is according to the WHO second international standard. And if the linearity is more and the free of cost calibrated control along with the smaller pack size, these are all the pain points of the customers who wants to use the niche parameters or those parameters whose clinical utilization is less, but if they are starting these analytes, their volumes are not much as compared to the thyroid panel. So if we compare the data of the positive and negative agreement of the SNIPE with the other systems, you can see here the SNIPE negative and positive agreement versus the other competitor negative and positive agreement is that the only one sample is negative on the SNIPE and positive on the other system, while the SNIPE has 4 samples which are positive on our systems and negative on the other systems. So if we talk about the positive percentage-wise agreement is the 98.95%, and the negative percentage is 95%. So the or of the rest of the 76 samples were negative on SNIPE and negative on another system, and 94 samples were positive on both systems. So according to this data, 217 samples, only the 5 samples were disputed, in which the one sample was negative on SNIPE and positive on other assay. So the positive rate of 98%, it shows that the other systems is giving you a false positive result probability is more as compared to the SNIPE thyroid antibodies. So the sample number was 175. The agreement was 97.14% overall. So if we goes to the thyroid antibodies advantages and comparison. So the biggest advantage is a higher sensitivity and methodology. If we compare with the Roche method of thyroid antibodies, we have adopted a sandwich method, and which is more sensitive than the competitive methods when you are detecting a small molecular weight compounds. So if you have a second better advantages of the SNIPE thyroid antibodies is a better specificity antigen from the humanization stimulus segment, and then this sequence similarity between the SWAN TSH antibodies complex from the Roche, while the human TSH is only 90%. There is a risk of missing detection with the Roche. However, the Roche has also a big challenge of biotin interference. So if we compare the Roche advantages or Roche SNIPE advantages versus the Roche, that we have a better specificity due to this human TSHR, which is there's a high risk of missing detection. While you know that this is in the thyroid antibodies assay in a SNIPE, we have adopted the humanized stimulus segment antigen, not the swine TSH antigen complex, which has an also a possibility of having a missing detection. And the second big challenge with the Roche is the biotin interference. Those countries where have a geriatric population, they have a big challenge of biotin interference because they are taking multivitamins for different disease treatment and for the quality life, even for the self medication, and then for some clinical condition, they are using the biotin, which is a major part of vitamin B complex. And the Roche is using a streptavidin coated microparticle beads along with the biointerfered antigen or antibodies to form a streptavidin and biotin bonds. And due to this, in some cases, they have reported a falsely elevated and in some cases falsely depressed. According to some FDA news, they due to the one death occurs due to the falsely suppressed results of troponin T, which may lead to some global new guidelines for the manufacturers to assess them to validate their interference of biotin in their assays, especially when they are using streptavidin and biotin in the reagent for the detection of analyte as an immunoassay analyzers. So if we talk about the reagents, what we have in this reagent, we have a magnetic microparticle beads and the compartment. We have a two reference numbers. So you can see that there is a change in initial 13020. There is a 13060, while the rest of the number is 3009, 3009M is same. So whenever you and your customers are going to introduce or start a new parameters of thyroid antibodies, they have to make sure that they have ordered a desired number of packed case size. Because if you want 50 tests and you have by mistakenly you have ordered the 100 tests, then you will receive a kit of 100 tests instead of 50 tests. So we are flexible in terms of number of tests, and we are flexible in terms of calibrated and control free of cost availability. So this is the volume which are contained in each compartment, like the magnetic microparticle buffers, low and high calibrators, and the buffers and the API labels and the diluent with internal quality controls. So we have a lyophilized magnetic microbeads. It means that you need to reconstitute the magnetic microparticle beads, and you have to allow to dissolve this magnetic beads and stand it for the 5 to 10 minutes. So this is the making a preparation protocol for that. And you know that the squirrel gently to ensure that the homogeneity, and during this squirreling you have to make sure that the dissolving solution does not contains the foams. If the foams is inside the reagent compartment of the lyophilized magnetic microparticle beads, you need to remove it either with the jester or the tip to minimize the impact of pipetting during the pipetting, the bubbles if they pick. And then you have to transfer the reconstituted magnetic microparticle beads to the compartment of the tube of the magnetic microparticle beads, and then you can load this microparticle containing thyroid antibodies reagent onto the analyzers. Yes, your question is, does biotin have any effect? Yes. If you want, after completing this presentation, if we have time, because we have now just 1 hour, I will show you some typical cases in which the biotin play a role and the FDA gives a warning to those companies who are using streptavidin and biotin in their assays. And I know that in the Russian market, you have a big competitor is Roche. And what are the challenges that you are facing in your market? So we can give you the important clue, and even that in Russia they are promoting more troponin T assay as compared to the troponin I, and as you know that they are claiming troponin T is higher specific marker as compared to troponin I, but according to the American Heart Association, the new guidelines are recommended that the troponin IHS is more sensitive and it meets the IFCC criteria for the troponin IHS high sensitive assay, which is better than the troponin T. And the troponin T values has some drawbacks. I will share with you a 15 minutes very quick presentation on the two key differentiators of SNIBE versus the Roche, or you can target the Roche customers for having a biotin interference, because there's a big challenge. The patient, the laboratory, and the physician. The patient does not knows that if he's going in the laboratory and he's taking the multivitamins, it may impact on their results. The lab even doesn't know that the patient is taking a multivitamin, or the results are falsely depressed or suppressed until they receive a complaint from the physician or the patient about the clinical correlation is different from the results value. Number three, the misdiagnosis or the mistreatment of patient, if on the basis of patient results which are impacted with the biotin, the customers or a patient is misled or misdiagnosed on the basis of this falsely depressed or elevated results. So we, as an diagnostic IVD market customers, we have to create awareness in the laboratory about the biotin interference, and we have to create a noise. It's very rare. The biotin interference occurs is rare because the geriatric population, in some typical cases, we have a few guidelines. But if this biotin interference occurs, what they have to need to do, I will also share with this key points as with you. So this is the procedure to prepare a thyroid antibodies lyophilized magnetic microparticle compartment. If we talk about the reverse T3, this is basically a reverse triiodothyronine. As you know that this reverse T3 is in basically inactive isomers of T3, both T3 and reverse T3 triiodo analogs of the T4s. So these are converted into the T4 almost. The majority part of the T3 is converted into the T4 and mainly produced by the peripheral deiodination of the T4 through the deiodinases. So the increased value of reverse T3 the increased value of reverse T3 concentration results from the upregulation thyroxine 5,3 deiodinase activity in the critical illness and the starvation and the fatal life. So you can see that if the reverse T3 value is decreased, that maybe clinical findings may lead to the hyperthyroidism and treatment effect, or maybe observation that the reverse T3 values is under the normal indicates drugs overdose. Or if the values are increased, that then hypothyroidism treatment effect observation, the reverse T3 values have an over the normal indicates drugs overdose. In euthyroid 6 syndromes, in which only the low circulating T3 levels is in spite of the normal gland function is called a euthyroid syndromes in these conditions. So This is about the reverse T3 clinical findings. If we go for a further related interpretation of thyroid panel with the different disease, you can see here you know the hyperthyroidism and hypothyroidism is related to the T3 and T4. If the T3, T4 values are high, usually the TSH is low and the FT4, FT3 are high. And in the primary hyperthyroidism, the reverse T3 should be the high. So this is a confirmation of the primary hyperthyroidism. So as you know that in the primary hypothyroidisms, the T3, T4 values are low, along with the FT4 and FT3 and the reverse T3, but the TSH values are high. So this is a typical clinical finding of primary hypothyroidism. But in subclinical condition, all the values are normal. But if the TSH value is low, that's called subclinical hyperthyroidism. If the TSH value is high, we call them subclinical hypothyroidism. And if we talk about the secondary hypothyroidism and the secondary hyperthyroidism, you can see that if all the value, including the TSH, are increased, they call them a secondary hyperthyroidism. If all the value of thyroid hormones, including the TSH, is decreased, they call them a secondary hypothyroidism. For the thyrotoxicosis and differentiation between the T3 and T4 thyrotoxicosis, it is also observed that in the T3 thyrotoxic, only the T3 will elevate, and then the T4 thyrotoxic, the T4 value is only increased. So for this, you can see also that also maybe observed in primary hyperthyroidism, but here the few markers like FT3 and then the reverse T3 are a good markers for the evaluation of T4 and differentiation of T4 and the T3 thyrotoxicosis. Along with that, the FT4, it's elevated in the T4 thyrotoxicosis, but it remains normal in the T3 thyrotoxicosis. In the euthyroid 6 syndrome, TSH will remain normal. Only the T3 or FT3 decrease and reverse T3 are elevated. This is called euthyroid 6 syndrome. So if we talk about the reverse T3 diagnosis and the assessment of the euthyroid 6 syndrome, if we go back to this area, you can see this is a typical picture for this case, like euthyroid 6 syndrome, in which the TSH remains normal, the T3, FT3 goes low, and only the reverse T3 goes up. So this is a typical example of euthyroid 6 syndrome. For this purpose, now we have to go for the further reverse T3 utilization. So if we go to this, you can see the algorithms. So if the serum T3 falls and there is a rise in the reverse T3 level, is most common with the anti-IS. That's in the past, anti-IS has been referred to a low T3 syndrome. So the previously it was considered as a low T3 syndrome, but now it's a euthyroid induced syndromes. So you can check here the normal range. If sorry. So if you go to this normal range, you can see that the reverse T3 values increase, and then it's also increased with the TSH value in some cases. And then we have T4, total T4 and total T3 values are decreases. Along with that with the FD4 values are slightly elevated with the FT in this range. And then you can see that this is an overall assessment of the euthyroid 6 syndromes according to the pediatric endocrinology journals. So According to the European Journal of Clinical Investigation, prognosis factors for the survival with the T3 is that the association of the low T3 levels or elevated reverse T3 levels with the mortality in this is in a heart disease cases and an acute myocardial infarctions and the geriatric unit and respiratory failures with the acute stroke are there. So according to this European Journal of Clinical Investigation, on the basis of this data, the T3 and reverse T3s are the prognosis factors for the severity of underlying illness in the NTIS cases. That's a typical helpful tool for the prognosis tools for the different diseases, myocardial infarctions and the cardiac disease related. If we talk about the SNIPE solution for the reverse T3, which is a unique in automation that no other competitors for the reverse T3 is available in the market. We have two generations, the first generation and second generation, and definitely the second generation is improved because they have a more sample type, and then they have a more improved incubation time and the 2-point calibration, along with the free of calibrators and controls, and improve onboard stability. And along with that we have an equally good assay range for the second generation of SNIPE Meglumi reverse T3 technical product as compared to the first generation. So if we talk about this overall summary, this is very much important slides because if you see that in these assays, we have a very comprehensive information. Which comprehensive information? There's a once in the routine, there is a one routine testing for the thyroid testing. Okay. So which are the routine testing? These are the routine testing like TSH, T3, T4, FT4, and FT3. If we talk about thyroid globulin antibodies or anti-TPO, these two markers these are called autoimmune disease markers. Like the thyroid antibodies are also as a part of autoimmune disease markers, while the other markers like for the cancer is thyroglobulin, calcitonin. These are the markers which can be used for the thyroid cancers rule out. So this is all about different cases in which the different interpretation of these markers are can be tested, like the Graves' disease, Hashimoto disease, and the thyroid carcinoma, either the papillary or follicular carcinoma. So if we talk about the market, the people have symptoms like metabolic syndromes or some other diabetes, chest pain, and other goiter symptoms, or some lethargicness. They go for a thyroid screening test, and then the overall population can go for the diagnosis of the thyroid disorders. And they have systems in which the countries have some prenatal screening or the newborn screening for the thyroid test, especially in some, even in the developing countries, some the newborns along with the total bilirubin, neonatal total bilirubin, the TSH hormone is also tested for the newborn disease screening systems, and also for the monitoring of the thyroid replacement therapy in people with they have a thyroidectomy or a hypothyroidism case, and in some adult which have thyroid disorders, that can be a target market for the thyroid testing. So usually in the labs, there are few panels which are frequently used by the laboratories. Like the number one is the thyroid panels, in which include the routine thyroid and the specialized thyroid markers, along with the fertility markers and the bone markers and the tumor markers and the anemia markers like B12 folate. So these are the key or a bread and butters for the labs who are reporting their results from the labs. So majority assays are belongs to the thyroid, and then followed by the fertilities and the bone markers and the tumor markers along with the anemia markers. So the hospital labs, the physicians, and the community medical centers, these are the target audience for your marketing strategies, and then you can market in these areas your product. So if we talk about the global prevalence, as you know that if we talk about the hyperthyroidism, which prevalence is with as compared to the hypothyroidism is less, which is exists between 0.1 to 1.25% of the global prevalence. And according to this data, you can see that the countries which are the Asian countries are more prone to more prevalence of hyperthyroidism cases, including with the North American countries, and then the countries have a less prevalence, which is include the China, and then Australia region have some low prevalence of the hyperthyroidism cases. But if we talk about the hypothyroidism cases, you can see here in the hypothyroidism case, the prevalence is more as compared to the hyperthyroidism is from 0.25 to 4.2%. And you can see that the North American cases, and then the China, India, and then the countries which have an Australian region, and some European countries are also have a typical prevalence cases of hypothyroidism cases. So this is a big market of thyroid screening, not only for the disease management purpose, or also for the screening purpose and the prognosis purpose of the treatment. If you talk about the thyroid cancers, which is an estimated standardized rates in according to the 2018 for the all ages and sexes, and then the prevalence of these in terms of percentage wise, per 100,000 is if the greater than 7.8% shows you then in the uh, dark blue colors. So you can see here the South Americans, the North American regions are more prone to this thyroid carcinomas, along with the China and then some African countries, and with the Australian regions, they have a more prevalence of thyroid cancers, according to the WHO. This is Internal Agency for the Research on the Cancer, according to 2018 data. So, this is about the thyroid panel. If you have any question, you can ask, or otherwise we have to start a new presentation. Any question? Okay, so if you have any question, you can ask me later. Let me start with my another presentation. Okay. So let's go to the next presentation. So can you see my screen? Okay, thank you. With the specific marker for the GD. So in this presentation, we will discuss about the thyroid antibodies introduction, and this part contains the thyroid antibodies production. So, as you know that the thyroid disease is a global problem. According to the guidelines, that the thyroid abnormality affect a considerable portion of the population, the prevalence and the pattern of the thyroid disorders depends on ethnic and the geographical factors. And as you know that almost 200 million people are estimated to be affected by the thyroid disease worldwide. So the 50 countries consider the thyroid disease to be a public health issue. And the 7 times women are more likely than men to be develop thyroid problems. So the clinical challenge in this thyroid dysfunction is the patient often misunderstand thyroid disease and the misdiagnosis of the thyroid disease. So the thyroid disease is one of the most prevalent endocrine disorder, but the clinical manifestation of the thyroid dysfunction vary considerably among the patient in their characteristics and severity. So you know that the misdiagnosis is also a big challenge for the thyroid disease, and it occurs because of the variabilities and the overlap in the clinical signs and the symptoms, and the successful diagnosis and management of the thyroid disease require the close collaboration between the physician, clinical laboratories, and the patient. So, thyroid panel testing is critical to fully understand the thyroid hormones relationship and achieve a clinical relevant patient thyroid profile. So for this purpose, the different algorithms are available for the thyroid markers monitoring and then discussion. So if we talk about the thyroid antibodies, basically usually it is major to investigate the origin of hyperthyroidism and to monitor the treatment of the disease. These can be stimulated or inhibited types of antibodies. And you know that in the thyroid systems, there is a negative feedback mechanisms. The pituitary gland, hypothalamus release the thyroid releasing hormones, which stimulate the TSH, and then this TSH stimulate the thyroid glands to produce thyroid hormone, which are T3 and T4. And these T3 and T4s are increase the metabolisms. If the immune system produce autoantibodies for these receptors of the thyroid cells, okay, so if the immune system produce the autoantibodies against these receptors, and then they stimulate the hormone synthesis, and the unregulated overproduction of thyroid hormones increase. That's a disease condition which is called that thyroid antibodies is also these are the bodies which can be detected through this. But in usually, if we see here, the regulated production, if they exceed the values, then through this negative feedback mechanism, the pituitary gland stop the release of TSH, and then this channel blocked, and then this TSH receptor doesn't stimulated by the thyroid stimulating hormones and stop the production of T3 and T4. So through this mechanisms, that if this autoimmune disease occurs, then it leads to the production of overproduction of the thyroid hormones. Okay, just give me 1 minute. So if you facing any problem, So now you can see the screen. Okay, thank you. So here I was describing the condition in which the autoimmune disease, what is the difference between a normal thyroid system, how the negative feedback mechanism has an impact. If we talk about autoimmune disease in which the autoantibodies, thyroid stimulating thyroid antibodies release in the bloodstream, and they combine with the TSH receptors and then produce, stimulate the thyroid cells to produce a thyroid glands, to produce a thyroid hormones. So this is a basic physiology of the thyroid systems. That's the way that this system works. Okay, thank you. So these are the thyroid receptors antibodies. If we talk about what are thyroid receptors and antibodies, as you know that these are the antibodies which are responsible for the many clinical manifestations and the autoimmune disease rule out, that's the Graves' disease, and the specific biomarkers for the autoimmune thyroid disorder. And the thyroid antibodies are grouped depending on the fact on the receptor signaling. Like if we talk about TSAB, that's in thyroid stimulating antibodies. So TSBAB, that's a thyroid receptors blocking antibodies. If we talk about the thyroid growth stimulating antibodies, this is called a thyroid binding inhibiting immunoglobulins. So these are different thyroid antibodies on rule out and have a different functions. If we talk about the thyroid stimulating antibodies, the major function of this thyroid antibody is to stimulate CAMP production and the iodide uptakes, which helps to bind with the thyroglobulin for the production, normal production of T3 and T4s. If we talk about the TSH receptors blocking antibodies, which inhibits the TSH-induced CMP production, iodine uptakes, and thyroglobulin synthesis. And if we talk about the thyroid growth in stimulating antibodies, which stimulate the growth cells, and then the thyroid binding inhibition immunoglobulins, which inhibit the iodine 125 TSH binding to those receptors. So these different immunoglobulins and the antibodies have a different functions, and then through this process, they regulate the thyroid normal function and the dysfunctions. If we talk about the thyroid antibodies detection development, so we have a different first generation development globally for the detection of thyroid antibodies. They have used a solubilized porcine and in the solubilized human in the first generation of the liquid phase autoantibodies testing. In the second generation, they have created a solid phase in which immunomobilized porcine, they have used peroxidase avidin biotinylated bovine TSH were used, and then monoclonal antibodies were used. And then it takes an hours as compared to the days of the first generation of the liquid phase. And the duration was between the early 80s and the early 90s. And then they have further improvement in the early 90s or the late 90s. But the second generation, which improved the assay time from days to the hours, that was introduced in the late 90s and the early 20s. And this duration, the scientists have developed the second generation of the solid phase of the thyroid antibodies detection method. The third generation thyroid antibodies detection is an MAP-M22. It's an porcine TSH with the peroxidase avidin biotinylated and the ruthenium M22 solid phase monoclonal. And then they have hours manual low automation. They have a while the ruthenium M22 methods has a minutes full automation, which was introduced in 2008 and 2012. So this is all the history of the first generation, second generation, and third generation of thyroid antibodies testing among the patients. So if we talk about the clinical application for the Graves' disease is diagnosis of the Graves' disease, differentiated diagnosis of the hyperthyroidism, and it helps to monitor the treatment and the recurrence of the Graves' disease and the medication response of person to person to make the personalized care more reliable in terms of monitoring, and it also helps to assess the risk of the thyroid disease for the pregnant humans and the neonates in some cases as well. So if we talk about more about the Graves' disease, as you know that the Graves' disease, the primary thyroid disease is greater than 99% as compared to the secondary thyroid disease. And the primary thyroid disease of 99% include the 80% is autoimmune disease, only the just 20% is non-autoimmune disease, which includes the thyroid goiter, subclinical thyroiditis, and the thyroid cancer. Prevalence is less than 20% of 99% of primary thyroid disease. The major portion of the primary thyroid disease is due to the 80% of autoimmune disease, which includes the Hashimoto thyroiditis and the Graves' disease, which are the best examples of hypothyroidism and the hyperthyroidism, respectively. So if you further goes to the Graves' disease, as you know that there are the name after the Sir Robert Graves, who was characterized in the 19th century, and autoimmune disease that's caused by the thyroid to swell and become overactive. So the healthy overall active thyroid is a normal healthy patient as compared to the hyperthyroidism cases, and it may lead to the hyperthyroidism is a condition it's called the Graves' disease. The clinical symptoms are the eyelid retractions, goiters, a swelling of necks or the larynx, or peripheral myxedema, that's an waxy discolor induration of the skins. These are the three typical signs of the Graves' disease. So if we talk about the Graves' disease condition and the normal disease condition, as you know that the TSH receptors antibodies bind to the TSH, thyroid antibodies bind to the TSH receptors, which also stimulate the thyroid hormone production. In the normal, you can see that the pituitary gland secretes the thyroid stimulating hormones. This is the pituitary gland, is stimulate the TSH to the TSH thyroid stimulating hormones receptors, and then this thyroid stimulating hormone act to the thyroid to induce the release of the thyroid hormones. So this is the normal process. But in the Graves' disease, this is an autoimmune beta cells disease antibodies which produce against the TSH, and then receptors that stimulate thyroid hormones through this thyroid antibodies, and then the overproduction of thyroid hormones occurs. So this thyroid hormones overproduction have been no effect on the TSH production and maybe shut down, and then which continues to cause the excessive thyroid hormones production. So this is the excessive thyroid hormones production occurs during this Graves' disease. So there is some more prevalence of hyperthyroidisms. If we summarize this data for the Graves' disease, in the key message for this is an prevalence cause of the hyperthyroidism is an iodine dependent geographical area, which around 20 to 30 annual cases are observed in 100,000 individuals. So the prevalence is not more than 1 to 1.5%. The women are more prone for the Graves' disease as compared to the men. In their lifetime, the peak incidence of the Graves is between the age of 30 to 60, and it's more increased amongst the African American people. So, excuse me. So thyrotoxicosis is in pregnancy has been estimated that the 0.2% of the overall thyrotoxicosis and 2.5% of subclinical thyrotoxicosis. So the USA data has estimated that 5.9% per 1,000 pregnant women per year is incidence prevalence of thyrotoxicosis occurs. Women be at greatest risk of hyperthyroidism in first trimesters, and the Graves' disease is most common cause of thyroidotoxis in the pregnancy. So this is a key message for the Graves' disease in pregnant women, for the thyrotoxicosis rule out, and the Graves' disease in women. So this is a typical example for the differentiation diagnosis for the Graves' disease. And you can see that between the sensitivity and specificity, the detection of TSH receptor antibodies in the Graves' disease is widely used in the routine test, clinical routine testing, and then operating characteristics plot analysis results shows that this thyroid antibodies testing is a specificity of 99.6% with the sensitivity of 98.8%. So this is an specific marker for the hyperthyroidism differentiation with the Graves' disease. It's a specific marker for this disease rule out. So if we go to the further hyperthyroidism differentiation diagnosis for the Graves' disease, the TSHR antibodies is a sensitive and a specific tool for the reliable and accurate diagnosis and the differential diagnosis for the Graves' disease hyperthyroidism. Like in the biochemistry testing, if you see in the algorithm, the TSH is normal, low or suppressed, go for the FT4 and FT3 and the different subclinical hyperthyroidism, T3 toxicosis or overall hyperthyroidism is observed. If we talk about the serological testing of TSHR antibodies, if it's positive, it's in confirmation of the Graves' hyperthyroidism. It's a negative, other cause of hyperthyroidism, which may lead to the adenoma, which may lead to the multicellular goiters or thyroiditis. So if the thyroid imaging ultrasound helps to give you the nodule is more than 2 centimeters, if yes, then isotopic scan is required to confirm the nodular goiters and other confirmatory tests for the serological service. So the technically availability of this TSH receptors antibodies is very helpful and predictive for the Graves' disease, even during the pregnancy and the postpartum as an extra thyroidal manifestation. So this algorithm is investigating a patient with a suspected Graves and hyperthyroidism. According to the American Thyroid Association guidelines for the diagnosis and the management of hyperthyroids and other cause of thyrotoxicosis, the conclusion is based on the diagnosis. It's a biochemical evaluation, the measurement of thyroid antibodies, including with the radioactive iodine uptake, and the measurement of thyroid blood flow on ultrasonography with iodine 123 gives you the evidence of the strong for the toxic adenoma or toxic nodular goiter, and then a strong recommendation for the moderate quality evidence for the diagnosis of the Graves' disease. So this is in a publication which also helps you to give the more differential diagnosis of the Graves' disease with the hyperthyroidism differentiation diagnosis. The most effective point, including the thyroid stimulating immunoglobulin testing for the diagnosis pathway of this thyroid antibodies testing. It's a cost and time saving, and it's a risk management care organization. No direct cost of diagnosis are reduced by up to the 43%, and the net cost of avoiding misdiagnosis and treatment of unexplained symptom is reduced up to 85%. So the overall cost reduction is 47%, and the time to diagnose as much as 46%. So if you more talk about the treatment and the recurrence of the Graves' disease and the guide, the medication, the patient with the persistently high thyroid receptors antibodies at 12 to 18 months can continue MMI treatment. Repeated thyroid receptor antibodies measurement after an additional 12 months or optional for the therapy with RAI or thyroidectomy. So this is another algorithm for the management of patient with the Graves hyperthyroidism can be confirmed by during using this algorithm. So the conclusion, according to this Thyroid American Journal for the Thyroid Association for the Management of Hyperthyroidism and other thyrotoxicosis cases. The key message for this thyrotoxicosis is a measurement of thyroid antibodies levels prior to the stopping ATD therapy is suggested, and then predicting with the patient can be weaned from the medication with the normal level of indicating greater chance for the remission. So to monitor the treatment and recurrence of the Graves' disease and guide the medication, this is also in a group of remission with a clinical significance for the monitoring and treatment of the recurrence of that. Then again, there is some more guideline for the assessed risk for the thyroid disease for the pregnant women and neonatals. The key message is a high level of thyroid antibodies in the late pregnancy is an indicator that the neonate may need to be monitored for the onset of neonatal hyperthyroidism starting a few days after the birth. So the risk assessment is also can be done for the pregnant women and the neonate during the pregnancy or after the delivery of the neonate to rule out the hyperthyroidism case. These are the few risk assessment thyroid disease for the pregnant women and the neonates is there. So you can also use different clinical manifestation and biological evaluation of hyperthyroid neonates. These are more risk assessment of the thyroid disease for the pregnant women, and then according to the European Thyroid Association guideline for the management of Graves hyperthyroidism, that if the maternal thyroid antibody concentration remains high 3 times, then the cutoff, then the monitoring of the fetus for the thyroid dysfunction throughout pregnancy is recommended. So this is very much important information during the pregnancy of or high-risk woman who have a thyroid impact. So if we talk about the SNP thyroid antibodies, so you know that this is the reagent compartment. You load from this region to the area, and this part is for the loading to inside the system. So this is microparticle beads. This is Cal1, this is Cal2, and then the other compartments are containing a displacing reagent, ABI, FITC antibodies, and the diluent. So on the basis of the technical specification of the reagent, our assay is based on a principle of automated chemiluminescence immunoassay technique. We have a limit of quantitation is 1 IU per liter. The measuring range is 0.5 to 800 IU per liter. The sample minimal volume, aspirating volume, is 10 microliters. So the 150 microliters is enough for the aspiration if you are using Hitachi cups for the sample processing. If your sample volume in the tube is low, or a pediatric sample if you are acquiring. So the test time is just the 38 minutes that we have in this assays. So if we go to the each component, that you know that we have a lyophilized magnetic microparticle beads with a buffer and the low calibrator, high calibrator, along with the buffers and the ABI label diluent and the control 1 and control 2. So we are providing the 2 level of control with the thyroid antibodies second generation kit, and you can see that they allow the disposable magnetic microparticle to stand for 10 to 15 minutes, and then after mixing you have to make them gently homogenized and avoid any shaking which may produce the foams. Then it will be difficult to remove a foam from the lyophilized magnetic microparticle bead solution. So the transfer the reconstituted magnetic microparticle to the tube of the magnetic microbeads, let's be careful about when you are transferring to avoid any foam or the bubbles inside this magnetic microparticle bead compartment. So if we talk about the competitors' information, yes, we have a very comprehensive menu for these parameters like thyroglobulin antibodies, anti-TPO, TMAs, and thyroid antibodies, and reverse T3. So still we are on edge. No one have this comprehensive menu in this area. Even the Snipe has no competition with Siemens, Abbott, and Roche. That we have a very comprehensive menu with all these leading brands. We have a TMA and reverse T3. Other competitors are not providing a solution for this automatic systems. So if we compare the SNIPE thyroid antibodies with the Roche and Siemens, you can see that we have an edge of uh, uh, small test pack size. We have a sandwich technique, and we have a serum and plasma recommendation for that. Minimum sample volume, free of cost calibrated control, improve linearity in our second generation assay. We have a traceability and standardization against the WHO 08024 materials. We have a calibration interval once in a week as compared to every day. And we have a limit of blank and limit of detection concept within the run precision and between the run precision. So this is the comparison of Snipe second generation and first generation versus the Roche and the Siemens analytes. So if we talk about more, so then in the next slide, we will see a comparison between the first generation and the second generation assays. We have the 50 test and then 50 test indirect and the sandwich principles. So human serum and plasma both are recommended. Volume is low. The linearity assay range is improved along with the 2 level of QC, and the within run precision and the between the run precision is excellent, which shows you the reliability and accuracy of our assay on the basis of the traceability is equally good as compared to the gold standard of the thyroid antibodies testing in the world. So if we more goes to the system comparison, we have an edge of thyroid antibodies versus the Roche. They are using competitive principles, and they are using a solubilized porcine TSH receptors, while the Meglumi is using a sandwich technique, and humanized TSH stimulus segment antigen we are using, which has a low chance of the interference as compared to the solubilized porcine TSH receptors. So if we go to the next, this is a comparison of high level of agreement with the other commercially available snipes, that you can see that the regression value is 0.91% on the basis of 182 samples has been run in compare with the snipe thyroid antibodies versus the commercially available thyroid antibodies, which gives a excellent correlation and the standardization of our assays. So this is all about this presentation. So if you have any question, you can ask. Just give me 1 minute, so I have to take some pictures. So if you don't have any questions, so I will share with you some more information about Roche. So anybody can share with me what are the challenges that you are facing in Russia with your competitors? If you are going to install a SNI product or you are going to introduce a SNI product, what is the big challenge that you are facing? Or if the customer says you that, oh, we have a Siemens, we have an Abbott, we have a Roche, which one is a big competitors for you in Russia? Hello? Anybody would like to share with me your concern or your big challenges in Russia, and what is the problem that you are facing when you are going to install a Snipe product at the customer side or have to discuss with the customers? Anyone can share their experiences, please? Okay. So yes, for the Abbott, it's a one calibration per lot. Doesn't mean that the second lot. Yes, Abbott also has the same problem. If the Abbott install a one kit of any analytes, the calibration stability is majority assays 28 days, but in a few assays the stability is 2 weeks. Like vitamin D in Abbott, they need to calibrate it after 14 days. But for the thyroid, all panels, they have a onboard stability of the reagent is 28 days. They recommend you either 720 hours or 28 days, whichever comes first. They need to utilize the reagent. If they are not utilized the reagent, they need to recalibrate on 29 days. So the lot calibration concept is existing, but it's not guaranteed that the next same lot will be give you the accurate QC. So according to the quality guidelines, it is recommended if you are using the lot calibration, you need to check the QC, all QC level at least once in a day to make sure that the previous calibration lot curve is valid for this kit. The first thing. We have also a same features. We can use the previous lot calibration on the existing kit. So this is also an option. The second thing, the Abbott has a big challenge of test utilization. They have a majority assay calibration is 6 point, and the 6 point calibration means they have a six calibrator: A, B, C, D, E, F. And with the F calibrations, they have to run the calibration in duplication. So it means if they want to run a calibration of one analyte, they have to consume a 12 test per calibration. If the calibration fail, they need 12 another test for the calibration. Okay. So we have a just 2 point calibration. We have a 10 point master calibration curve in the RFID of the reagent. Once you have scanned that, it also show you the master calibration. Right? And any other challenge that you are facing? Are you interested to see the Roche weaknesses with the product of Roche? Please share with me which one is your big competitors: Siemens, Beckman, Roche, or Abbott? Anyone can give me in email, or you can type it on the chat. Okay, Spasiba, thank you. So Roche and Mindre is now a big challenge for you. Good. So if you have a time, I can, right now there are 7 minutes left. Let me try to finish my very comprehensive one presentation with you in just 5 minutes, 7 minutes, but it's not possible. But let me try. So please confirm me that can you share? Can you see my screen? Everyone can see my screen. Irina, Sergi, Sergiuk. Spasiba, spasiba. Okay. What you say in Russian language? Harashu. Okay. Harashu means okay. So let's start with the competitor intelligence. You have a big competitors in your market is a Roche. So let's talk about the Roche. The Roche history is very strong. In 1896, they have founded when the Industrial Revolution was changed the face of Europe. They have launched the thyroid preparation of the adrenaline, and then they have developed the diagnostic market of 1968 creation, and they have acquired a Boehringer Ingelheim, a German company. It's basically the Roche was a Swiss company. They acquired a German company of Boehringer Ingelheim, from where they have started the operation of the four core business, like vitamins, chemicals, diagnosis, flavors, and fragrance. The Roche Diagnostic in 1991, they have acquired the rights for the marketing of polymerase chain reaction from the Centis Corporation. And then they have capable to use the diagnostic, the most sensitive test for on the basis of molecular testing. In 2008, they acquired a US-based company, Ventana, that is a tissue-based diagnostic histopathology-based company that's increased the Roche diagnostic portfolio. They have a different Roche Cobas analyzers. This on the basis of their throughput. They have a very comprehensive menu. They have a Magluni principles. If we talk about the principle, they have a first weakness of the Roche is their limitation of their interference. If the patient, please jot down this presentation, this is very much important. If the patient is receiving a biotin therapy with high biotin dose, means more than 5 milligram per day, that the Roche are recommended that the sample should be taken at least 8 hours after the last biotin administration, because the biotin is playing a very important role in for the geriatric health, for quality of good life. But if the patient is taking and going for the Roche testing, they are facing some issues. If we talk about more in terms of other interferences, let me go to the slides, which has a presentation on the biotin interference. So, according to the FDA feedback, due to the false results, misdiagnosis and deaths occur, and then FDA has some instructions has been given. The patient with the having biotin in the patient 7 can cause a falsely high or falsely low results. The biotin safety communication has been updated by the FDA. The Roche high sensitive troponin T should not be taken from the patient receiving the therapy with high dose, and it's recommended until at least 8 hours following the last biotin administration. If a chest pain patient presenting to the emergency department required an immediate laboratory workup and cannot afford to wait for the 8 hours. So this is a very big challenge. If the patient has a chest pain and he's taking a biotin as a multivitamin of B complex, the probability of troponin result interference is more, and may falsely low results of troponin T is reported, and then this biotin interference is also reported in this biotin. So according to the biotin is not an issue of Abbott, not an issue of Siemens, not an issue of Disorin. Sorry, Siemens has also the issue, and does not there those companies who are not using a biotin and streptavidin captures molecule. So if we compare with the Roche and Siemens platforms, if we go to the some clinical features that some Pompe diseases, the clinicians then also observe that the troponin I values is increases. If we take after 2 hours, then some myocardial infarction negative pros values is different. If we go to the current challenges, let's talk about more about the biotin interference. If these are all troponin T versus the troponin I results, and if we goes to some more information for the biotin interference, this is more about troponin T versus troponin I, and then the risk stratification in high sensitive troponin I. So just give me 1 more minute, so I will show you the specifically the biotin. Yeah. So this is important. If you have a big competition with the Roche, the biotin interference. So the recently awareness regarding the biotin interference with the laboratory testing has led to the internal assessment for the assay to ensure the confidence. So if we go to the biotin, what is biotin? It's basically a water-soluble vitamins, and it's also known as a B7 or B8 in France. It's basically a key nutrient required for the carbohydrate, fat, and protein metabolism, and then dietary sources meat, dairy, cooked egg, and yeast, along with the grains, nuts, and vegetables. So if we go for biological functions of the biotin, the overall it's play a very vital role as an coenzyme for the carboxylase and the TCA cycles. These are the symptoms of the biotin deficiency, and the big challenge is the biotin helps to support the metabolism, energy production, fetal development, hair, skins, and nail. It's a very essential vitamin for supporting overall health. The biotin play a role in the medicine and the health and beauty sectors as well. In inborn error of the biotin metabolism, it has been treatment has been given for the patient from 5 to 20 milligrams, and then clinical trials supporting high dose biotin for the disease such as multiple sclerosis, and the 50% of women they are using biotin deficiency during the pregnancy. So these are the biotin utilization. The multivitamin contain 30 to 40 micrograms, but the daily recommended intake of the B12 of this biotin is 30 microgram per day. The biotin supplement may contains 5 to 10 milligrams, which is much higher than the 30 microgram per day. And even for the hair, skin, and nails product, it also contains 5 to 40 milligrams of biotin. So some people are prescribed biotin for the medical reason. These were for the self-medication or for the maintenance of the beauty or for the beauty purpose they can use. But in some medical condition, people are using a biotin in their diets, and this typical diet may contain 35 to 70 microgram per day, and then the bacteria in the intestine can also make a biotin as well. But if some people are prescribed between 5 to 300 milligram per day, these conditions are maybe a several layer inherited metabolical disease like biotinidase deficiencies, holocarboxylase synthase deficiency, the biotin thiamine responsive basal ganglia disease, and may also have a novel therapy in the multiple sclerosis. For the multiple sclerosis, the patient is given administered 300 up to a 300 milligram per day the biotin. If the patient is taking a 5 to 10 milligram, in some patient is prescribed with the alopecia, muscle disease and muscle cramps, and some diabetic patient, there is a recommendation of the person there. So for the beauty purpose, and for the cosmetic purpose, the biotin is taken. And then the important point is the biotin peak serum level is acquired in 3 hours, and the half-life of biotin in the serum is 15 hours. So in some repeated cases, some due to the renal dysfunction, it may take a longer period. And if the biotin high dose of 300 milligrams, peak level may be acquired at 1000 nanogram per ml. So the some immunoassay can show the interference even with the biotin serum concentration is low at 10 nanogram per ml. So the case studies. This is very much interesting case studies, but please let me know if you have a time. We are exceeding 5 minutes as other than the commitment. So if you have a time, if you allow me, then I will proceed it further. Otherwise, I will complete it in the 1 minute, 1 or 2 minutes. So are you interested for the biotin interference and what are the weaknesses of Roche that you can utilize these weaknesses against the Roche, and then the SNI product has a better edge of over the Roche product. So would you like to give me 10 minutes or 15 minutes? How much time you will give me? Because right now its time is 6 minutes over than the expected time. How much time you will give me? 10 minutes or 15 minutes? Okay, thank you very much. Or I have to say you in Russian language, thank you. So what I have to say, I say spasiba. Okay, spasiba. So there's a one typical case studies. A 55 years old man with the multiple sclerosis was referred to the hospital. This is very important and the typical case. The patient was multiple sclerosis, admitted to the hospital with a thyroid unit and markedly elevated FT4 and FT3 results and the low TSH value. These results suggest the patient has a thyrotoxic and maybe have a Graves' disease. So the diagnosis becomes changed for this multiple sclerosis patient. When the thyroid scan of iodine 123 shows a normal thyroid gland with normal radioiodine uptake, the patient shows no symptoms of thyrotoxicosis or hyperthyroidism. Then the biochemical results were discordant or discrepant with the patient clinical assessment. Further investigation for the assay interference from the drugs or other compounds were performed. And that the patient, it was emerged or it was root cause was that the patient has taken high dose of biotin for the treatment of multiple sclerosis, which is 10,000 times higher than the intake of 30 microgram. As a study has been suggested that the biotin might be beneficial for the multiple sclerosis. And then the discontinuation of the biotin supplement result in the FT4, FT3, and TSH results returning to the within reference range value in a just few days. So this has been reported that the biotin interference occurs with the 55 years old man with the multiple sclerosis. Okay. So if we go to the biotin interference, biotin is usage worldwide is not well understood. Market research, according to the USA, suggested that the Nielsen data, 300 million biotin capsules are sold monthly. You see, 300 million biotin capsules are sold monthly. Google Analytics, threefold increase in biotin shopping searches. Amazon, #1 supplemental seller, that's the biotin. So the capsule contains 5 to 10 milligram of biotin, current supplement formulation. So according to this, the biotin supplementation in the US state is growing in both utilization and in terms of concentration. So this is again a big challenge for the all market that the biotin interference increases. So let's talk about the case reported drawing the venous interference with the laboratory testing. The endocrine journal, be aware of the biotin in 2016 journal. In the test interference, beauty fades ugly downside the cap today. In the case studies of different that the fastidious Graves' disease due to biotin interference is given. So what is the challenge? The patient, he may not realize that they are taking a supplement that contain a biotin, and then the lab which they are going, it may face a biotin interference. And the lab will not know that the specimen containing a biotin has an interference with that patient or not. The physician take the decision on the basis of this inaccurate lab results. So being an IVD representative, this is our ethical right to educate and create awareness to reduce the potential of diagnosis error caused by the biotin interference. So how the biotin interference cause falsely elevated high or low test result depending on the methodology. If you see that the streptavidin biotin free captured molecule, if they increase free signals, the streptavidin bind in the competitive assays with the serum containing biotin, and then the high results will shows high signals, and then the falsely elevated results. And in the competitive or non-competitive or sandwich principles, then they bind with this, and then the low results is observed. While in the Abbott, in the SNIDE, and in the disorin, there is no streptavidin biotin interferences occurs. If we are using the biotin streptavidin capture molecule, it is important to understand the biasness of the biotin interference in the case. This is the relationship biotin dose and serum level and an impact on the lab. Results require further investigation. And the key message of this is that in one study, one participant interference persistent for up to 25 hours after a single 30 milligram ingestion of biotin. So it means that this patient who was taking a 30 milligram of biotin, the blood has an interference of biotin up to 25 hours. And in another study of anti-thyrotropin receptor antibodies returned to the normal in 7 days after discontinue of biotin treatment. So the laboratories are advised holding lab test 8 hours after taking biotin, but the length of the time biotin implemented may be much longer. So these are the streptavidin coated capture design is used by the many diagnostic companies like Beckman, Immunodiagnostics, Orthoclinical, Roche, and Siemens. These are the assays which are impacted by the biotin interferences like FT3, FT4, total T3, T4, TSH. So the assay is susceptible to the biotin interference according to the biotin-based immunoassay high risk for the analytical interference by the biotin supplement. you can see that the highest number of biotin interference are with the Roche. You can see here the total 66 assay were reviewed, and then the overall from the different companies, 374 assays available from the USA market from the 8 different manufacturers reveals that the 59% of these assays use biotin in their assay format were at a risk of interference from biotin. So you can see that among 374 assays, 221, which is almost a 60% assays who are using a biotin in their assay format, were at risk of interference from biotin. And for the Roche, 66 assays, 44 were on a high risk. From the Vitros, you can see that among the 37 assays, 28 assays were high risk. From the Siemens platform, Centaur, Emilite, and the Abbott Architect has no impact because they are not using biotin or streptavidin in their assays. Can you send for us all comparison presentation about differences in Roche, Abbott, etc.? Okay, my name is Asif Iqbal. So I can write it here. Anton, this is my name, Anton. If you need any presentation, you have to contact the global support team from your Chinese colleague. No issue, no problem. So you can contact with the global support team. They will provide you this presentation, right? Or your Chinese colleague will help you to give you this presentation. So this is other than the official time. I'm just giving you this information just to create interest that the product of SNIPE is not an average product. We are going to be an emerging leader in immunoassay diagnostic company because we have a very broad menu, 235 analytes with the fastest 600 tests per hour immunoassay throughput analyzer, which is Meglumi X8. And we are increasing our portfolio of immunoassay, and we are growing very fast. So for us, the future maybe of SNIPE is more, and our product is equally good to the Roche and Abbott. The only challenge that you may face in your market is the Roche and Abbott and Siemens and the Vitros. They are older than us. Only the customer has a more confident. But our product is equally good to the Roche and Abbott. So, and we cannot say that we are better than Roche, but we know that we have a good strength in our product because we are not using streptavidin and biotin, which is interference is well known according to the FDA guidelines and other guidelines. Okay. So you can see that there are different assays. So if the customers or labs are using streptavidin biotin binding serum biotin, they need to develop some other procedures to capture the analyte on the solid phase microparticle, and then there will be no biotin or streptavidin in the reagent, and then they have no effect by the serum biotin levels. So the FDA biotin safety communication, according to the November 28, 2017, biotin in blood takes from the patient who are ingestion high level of biotin in the dietary supplement can cause clinical significant incorrect lab test results. So the FDA has seen an increased number of reported adverse events, including one death related to the biotin interference with the lab test. So Clinical Laboratory Standard Institute has recommended the manufacturer to change recently the testing of biotin interference is now performed by the manufacturer from the concentration of 3,510 nanogram per ml of biotin. So this change is previously recommended by testing of 7.5 nanogram milligram for the biotin. So what can be done to detect or even more remove a biotin interference? This is a very pre-treatment technique, very tricky parameters, but for the emergency patient and for until the lab doesn't receive a complaint, they doesn't know that what is the interference occurs in their results with the patient. So lab should be aware about the biotin interference in the immunoassay using the substituting biotin binding, and does not allow for the recommendation about the length of the time needed for the biotin to clear from the blood. And there is a very important steps are given. So the SNIBE assays are designed not to be impacted by the biodescent. So this is the edge of the SNIBE. All assay across the board that we have no interference with the biotin. So if we talk about the other part, which is troponin T is better, but in a real scenario, the troponin I HS is much, much better than the troponin T because the troponin T has some drawbacks. So this is all about my presentation with an extra time of 19 minutes. If you have any question, you can ask or you can give a feedback. So you can take my contact. But for the presentation, I would like to say you that you have to contact your Chinese colleague, or if you need a more special time for any specifically to how to target the Roche customer side, and if you compare the smallest instrument Meglumi 800 or the next generation X3 analyzer with the Roche E411, so it's a no comparison. We are much better in throughput, much better in the reagent handling, in assay interference, and the menu wise, we are much better than the Roche. So it will be great if you want some more training. You can ask to your Chinese colleague. You need a specific presentation on the Roche or Abbott or a Beckman or a Simmons. So that's all for today. If you have any question, you can ask, or it's a little bit challenge for me because you didn't ask any questions. So I'm a little bit confused that my training was is good for you, or it's a good information for you, or if you need sorry, do we have any comparison? No, we do not have any. I will jot down this question and I will send it to my team leads, and they will prepare. Okay, they will prepare a comparison in the future slide for the Mindray.
Okay, thank you very much. For us, it's very important because in Russia, we have right now a lot of Mindray analyzers, and each day more and more Mindray analyzers. That's why Mindray is the biggest competitor for us right now. That's why it will be very important and very useful for us, the information about Mindray. And Roche also the biggest competitor. That's why thank you. And for us, it will be also very useful if we will have a table with comparison. But as far as I understood, we should ask about it the team in Shenzhen. Yeah.
Mm-hmm. Just give me 1 minute, so I have to jot down your suggestion. That will be great.
Okay.
So you need a comparison with the Mindray, the number one question.
Number one, yes. And the second one, it will be useful for us to have a table with comparison Roche SNIPE, Siemens SNIPE, and Mindray SNIPE. If it will be like not in presentation, but short information in table, in Excel table maybe, if it's possible. No, if it's possible, it will be great if we will get the presentation about it. But as far as I understood, we should ask about it the Chinese team. Yeah.
Okay.
Okay.
So you want a comparison of Snipe versus Roche, Snipe versus Siemens, Snipe versus Beckman, apple to apple comparison in terms of instrument and in terms of consumables, in terms of assay menu. So you can pick that key point, that how we can market the key features or the strength of Snipe versus the competitors. That's the main objective.
Yeah.
So as far I know, they have this presentation. So if you have a Chinese colleague in Russia, so you have to request them. They will arrange a presentation of Snipe versus Abbott, Snipe versus. Actually, I have also prepared these presentation like Snipe versus Architect, Snipe versus Alinity, Snipe versus Roche.
Good.
So I have this presentation, but you need to talk to your Chinese colleague who will talk to your the global training team, and they will assign someone to give you a training for the specific company. Like today, they will give you the training on Roche versus Snipe, and you will know about the Roche everything, and you will know about what are the strength of Snipe versus Roche. And the next day, you may be required a comparison of Snipe versus Abbott. And in your market, you maybe have Alinity and Architect, both analyzers. So
both
you
analyzers we have
two different comparison. One comparison of Snipe versus Architect, one comparison of Snipe versus Alinity. What are the edge of Snipe versus Alinity, and what are the weaknesses of Alinity? What are the strength of Snipe? What are the edges of Alinity? It will tell by, actually I have a both companies experience, Roche and Abbott. That's why I have prepared this presentation. So, in my opinion, if you if you send an email or talk to your Chinese colleague, and they will arrange this. And
yes, okay, we will talk with our Chinese colleagues. Okay, about it.
Okay.
Thank you.
Okay. Thank you.
Thank you very much. Bye.
Okay, thank you very much. If you have any questions for this presentation, I've shared with you my numbers, so you can drop in any message. But I hope my presentation helps you for the future customers calls and for the improvement in your knowledge as well. Okay, thank you very much. Okay, Sergi, it is better to drop a message on my mobile, so I will send you the screenshot that what you required. And please send me the message on my number, jot down my number, and send me the message on my number. I have just, this is my number. It will be a great pleasure for me to, this is my name. I'm from Pakistan. So, okay. Thank you. Thank you very much. If you have saved this number, so we can close. What the meaning of spasiba? Okay, but in my spasiba. Yes, I remember spasiba and idraste, privet, and mia zabut. Dobraya Otral. So I try to learn Russian if I want to come to the Russia. Thank you very much and goodbye. Have a nice day and das vidya naya. Take care. Bye-bye.
Recording stopped.